Hi, everyone, and welcome to the Global PAD Impact Awards, where we celebrate outstanding achievements in peripheral artery disease care. Today, it's my distinct pleasure to present the U.S. Vascular Surgeon of the Year for 2024 award, recognizing excellence in the treatment of peripheral artery disease and honoring a surgeon who has made an extraordinary impact on patient care, not only in her region, but across the nation. This year's recipient, Dr. Jacqueline Majors from Memphis, Tennessee, has revolutionized PAD treatment through her holistic and patient-centered approach. Dr. Majors stands out for her unwavering commitment to viewing each patient as a unique individual, tailoring her approach based on their specific presentation of disease rather than relying solely on general algorithms. What truly sets Dr. Majors apart, though, is her innovative interdisciplinary team approach. By fostering collaboration amongst various specialties, she ensures that every aspect of a patient's health is considered in their treatment plan. This comprehensive strategy has not only improved patient outcomes, but has also set a new standard, I think, for PAD care that should be replicated across the nation. Dr. Major's dedication to fighting for every patient is just truly inspiring. She goes above and beyond, exploring all possible options to save life and limb and getting, patients to not only improve their quality of life, but also be able to stand on their 2 feet much longer. And her efforts in Memphis have yielded remarkable results, significantly reducing amputation rates and also minimizing repeated treatment, something that we are trying to do not only across Tennessee, but across the nation and around the world. So that's really, really important. Moreover, Dr. Major's impact extends far beyond her local community. Through her research participation and commitment to education, she has influenced PAD care practices across the U.S. And her work just continues to inspire the next generation of vascular surgeons as well, encouraging them to push the boundaries of what's possible in PAD treatment. So without further ado, I could keep talking about Dr. Majors forever and ever and ever because she is just a true hero in PAD care. I want to introduce the recipient of the U.S. Vascular Surgeon of the Year Award for 2024, Dr. Jacqueline Majors. Thank you so much and congratulations, Dr. Majors.
Thank you, Kim. I appreciate it. I'm so happy to be here and so honored to have received this award. I love what the Global Network does in connecting patients, and I'm just happy to be a part of this.
It's just so amazing to see that, such a quality surgeon such as yourself focusing on PAD. What brought you? I mean, being a vascular surgeon, there are so many different areas you could specialize in. I mean, of course, you could be, the do all, but you've really doubled down on PAD. Why is that? Why peripheral artery disease?
Kim, I think it really is my background in exercise. So I was an avid soccer player all the way through high school and even Division I soccer. And even after that, I became a soccer coach. And I saw how much just mobility, exercise, all of that really influences people's longevity as well as their ability to fully participate within their community. And so getting people exercising, moving, and staying mobile for as long as possible in their life, that really became a passion of mine. And I really think it has to do with my background and how much playing sports and being active has influenced and enhanced my life.
Wow. And so, with that, there are a lot of doctors that literally will tell a patient, okay, well, go ahead and walk, walk, walk. They don't even tell them how to walk effectively to grow their collateral vessels. But you know what? Nothing can be done. Nothing should be done. Just walk until, you have an amputation. They won't even try. But here you are as a vascular surgeon on the cutting edge of literally treating the most advanced stage of PAD, known as CLI or critical limb ischemia. And yet you are one of those that's like, hey, just, exercise, 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 but you know when to say when, and you know when to say, hey, you know what? There's always something that we can do. How is it that you adopted that philosophy, that can do attitude to exhaust all efforts to save a limb?
Well, I've always said that vascular surgeons are pathologically optimistic. We have to believe that we're making a difference in patients' lives, and which we are. And so, one of the things that I discuss with my patients is that I don't cure their disease. There's no medication, there's no surgery that actually cures their blood vessel disease. My objective is to have them preserve their limbs and keep them walking as long as possible. And so educating the patients on the goals of care and what they are and what there is important to them, I think is essential to tailoring each type of treatment plan to the patient. And so having that discussion with them is essential to find out what's important to the patient and how do we tailor, whether it is starting off with lifestyle changes or if they progress to critical limb threatening ischemia, then what is the advanced type of treatment we can do to allow them to eventually start walking again?
I totally agree with that. Even before this, you and I had this, 1 hour discussion impromptu recently, and I was so inspired by the conversation and your approach. And one of the reasons why, this award means so much is the way you do tailor it. With PAD, I know everyone's fighting to come up with an algorithm, but I don't know that there is a true algorithm for the treatment of PAD because as you just every single patient is so different based on their goals. If you have someone that literally their whole day revolves around getting up from the couch and going to the bathroom and going to the kitchen and like that is their life, they have no desire to go out. Are you going to go ahead and do a treatment where you open up the arteries, whether it's interventionally or doing a bypass, to give them maximum blood flow? Probably not. You're probably going to get them on maximum medicinal therapy, pharmaceutical therapy, and encouraging them to do more walking to improve their collateral network of vessels versus someone, let's say, who is a can do person. They want to get out, they want to run a marathon. Maybe they won't want to, run a marathon, but they at the very least need to be able to get the heart benefits, the cardiovascular benefits of a workout, right? So they're in cardiac rehab for their heart. Well, they got to be able to walk through it. So you might give them a little extra blood flow just so they can get the maximum cardiovascular benefits from their rehab program, right? So you got to tailor it and really consider each individual patient and what their goals are.
You're absolutely right. So when you're talking about claudication in that sense, and claudication is the repeatable pain, discomfort, and cramping that happens at specific distances for each patient. And so working with them first is, okay, well, what are you doing when the pain comes? Can you make it through the grocery store without stopping? Is it affecting your ability to work? For example, I'll have patients that work in a warehouse and they have strategically placed chairs along the wall of the warehouse because they know that's where the pain starts and they have to stop before they can even walk to the end of the warehouse. In those instances, those patients need an intervention. That is no way to live, that is affecting their job performance and their ability to even do daily activities. Now, like you said, if there's a patient where they start having some pain at a mile or half a mile of walking, that patient is not in a sense where they necessarily need an urgent intervention. And as we find with more and more data, if we intervene too early with aggressive revascularization strategies on patients, we're actually now converting them over to, could convert them over to a critical limb ischemia, where now they're at risk of amputation, where prior, with a little bit of medication and lifestyle management, they could have gone many more years with the blood flow status they have without aggressive interventions.
Very true. And one of the reasons, you mentioned you want to reduce the repeat of procedures. And one of the reasons that I was in our team was really impressed with your approach is you are able to actually minimize repeated interventions. This is something that we're trying, around the world to do. What approach do you take, clinically and technically to reduce repeated interventions, and then that coupled with inspiring, that conversation that you have with patients to inspire them to be a better partner in their care along with that?
So one of the data-backed interventions that we do specifically at my outpatient facility here, as well as when I'm in the hospital, is that we actually use drug-coated technology. Now, drug-coated technology actually delivers drugs that actually prevent what we call scar tissue forming. It's actually called intimal hyperplasia, but talking with patients, they understand when you say scar tissue. Whenever we go and intervene and I'm putting in balloons or wires or doing specific techniques like different types of atherectomy, I am causing trauma to their blood vessels. And so their body's going to do what it does naturally. It's going to heal that area. And some people actually overheal and form thick scars in that area, which can cause a narrowing to reoccur. So a drug-coated technology, whether it's a balloon or a stent, actually tells the body, don't form scar tissue in this area. And so that is one reason why we have, we don't have to do so many repeated interventions because of that specific technology. Another way is just by the specific patient management. I talk to patients all the time. When we're in a limb salvage situation where we are trying to prevent an amputation, we are going to be very aggressive in monitoring. You're going to see me once a month along with your wound care specialist while this wound is healing. And we're going to do ultrasound surveillance and wound progression monitoring. And you may need a repeated intervention during that time when we're in that critical stage. But down the road, after your wounds have healed and you're walking and you're doing well, if one of those vessels does have a reoccurrent stenosis or it does occlude, but you're completely asymptomatic, that's not someone that I go in and re-intervene on. It's not necessary, and I'm placing the patient at multiple risks. And so these are the different types of strategies we use to try to minimize interventions to the patients, but also do what needs to be done for limb salvage.
And what we tell patients is that not one of these procedures is durable, and it's only to get you that much more blood flow. And we tell the patients to say to the doctors, as you know, there are some doctors that are very aggressive no matter what. They figure while they're in there, they might as well get maximal maximum luminal gain. And I'm like, why can't you just go in there tiptoe? Just give them that much more blood flow. Doctor, less is more. Let's just tiptoe in there, kiss it with the balloon if possible. Get me enough blood flow to give me some relief so I can walk, walk, walk to grow those collateral vessels. The whole goal of these procedures, correct me if I'm wrong, heal a wound, relieve symptoms so that you can walk further and faster to grow your own collateral network of vessels.
Well, and like you're saying, there's a little bit difference in collateralization. So when we're asking them to walk, we're actually asking their muscles to now behave more efficiently. It's like a marathon runner, or a chronic exercise or something like that. It's not necessarily that they build so many more blood vessels. Their muscles just become so much more efficient at obtaining oxygen from their bloodstream. So that's what we're doing with claudication patients, is getting them to be more efficient with the oxygen that is being delivered. But you're absolutely right. When you have a wound, there is an exorbitant much more increase in demand of oxygen requirements, nutritional requirements that the wound actually needs over your baseline. And that's why when patients will be like, I didn't have any pain, I could walk, but all of a sudden I had this wound and it is not healing. Well, because now you're having requirements and demands beyond your baseline. And that's why revascularization, improving the blood flow is so essential when you have the wound.
And patients always ask, well, my foot's tingling, my foot's numb. Why won't they do anything about my feet? And this was an important discussion that you and I had. I want to have you share what are the indications, clinical indications, medical appropriateness for actually treating those vessels into the foot.
Right. So you have as you go towards the foot, the vessels get smaller and smaller. And the smaller and smaller vessels, we have less and less tools that can have long-term beneficial effects. The reason why people would actually intervene and aggressively treat those blood vessels down in the foot are for limb salvage. It is for wound presence or rest pain. When you get that discoloration, and that rest pain can actually progress to gangrene. So those are the reasons of indications for treatment within the foot. I know, like you said, that there are some facilities and doctors that are trying to get a quick fix on some of these patients and relieve this numbness and tingling they may have by aggressively ballooning and treating these vessels in the foot. Unfortunately, like we talked about, these are not long-term durable treatment plans. And so what happens is that they'll continue to do that until they can't do it anymore. And then what happens is that then they'll send the patients to a vascular surgeon, someone like myself. And then unfortunately, the only thing I can offer the patient at that point, after they've completely shut down all the vessels in the foot, is a possible amputation or palliative treatment.
Yeah. I mean, there's only so many times that you can go in there and you can treat those smaller vessels. And so, because that's what you're really doing is you're going in there and no matter how many times you're causing trauma to the vessel. And finally the vessel is just going to go, whoa, I'm done. Stop poking and prodding at me. It's just over. But what's great is that one of the things that we are working with patients on is we do Tai Chi on Mondays, where we work on slow movements to increase circulation throughout the legs. Number one. Number two is we have a gentleman by the name of Dr. Kevin Morgan. He's PhD, and he's a PAD patient. He's an Ironman triathlete, former veterinarian, as well. The man that could do it all. But he had, AAA, and he has complete occlusions in both of his legs, like literally blocked all the way down. Never had a procedure, but he shares ways in which he's been able to improve his circulation naturally. And especially in his feet, one of the things he does is what he calls yoga toes, where it's stretching the toes out, bringing them in, stretching them out, bringing them in. And he has different exercises like that that we focus on, because there are ways in which you can improve the circulation. And it's proven and you, again, you can, I talk because sometimes I want to make sure that, you either affirm or deny what I'm saying, but there's the deep vein arterialization, right? Where they hijack the vein and they reroute blood flow from the, artery to the vein to perfuse the foot and heal a wound. And those don't last very long. The whole idea behind them is to, get the vessels in the foot, to start kind of developing new ones, or rerouting blood flow through there. So it makes me think, like, then why do you need someone to just go into the foot if the foot can actually do it on its own if you kind of work it a little bit? Maybe you can
Right.
put it more eloquently than I did.
Those are very special situations in patients. And those are when we talk about, excuse me, but patients will have actually what we call desert foot. And what that means is they have vessels that reach the ankle. And then once the vessels reach the ankle, they just branch into these very teeny tiny unnamed vessels within the foot. And when you see that, these vessels can be like as thin as a pencil line. And so with that, those vessels are not adequate to heal large wounds on the foot. So something as aggressive like as deep venous arterialization certainly should be reserved for patients where this is a limb salvage situation.
Right,
Without this procedure, the patient will absolutely progress to amputation. And so that's why that you need blood flow and you need it now. The
right,
types of interventions that we're talking about with exercise and different types of different external techniques like electromagnetic stimulation, compression pumps, vibration pads, things like that that can stimulate blood flow, those take some time. And these people that are in the critical limb ischemia situation, they don't have that time. They need blood flow now, otherwise they're going to end up with an amputation.
right. My point there was that how remarkable the body is. That's the whole theory behind it, is that that procedure is not really that durable. The whole idea is once you at least get some blood flow down there, right? The body starts working and it starts the whole it starts building the collateral network of vessels down there in the foot and is able to maintain, that foot long term.
That's
Does that
right.
make sense?
Yes.
So I'm just making the point that, hey, your foot's remarkable. If you work out that foot, if you're stretching those toes, you're building those muscles and getting things going, you could actually end up never needing anything done to your foot. But you got to work it. The body's like this miraculous model that can actually respond to that exercise that you're doing and get that blood flow pushed into those muscles, the tissues, and everything like that.
Kim, you're exactly right. I had an 84-year-old patient in my clinic this week that I've been following, and he has bilateral superficial femoral artery occlusions and a popliteal artery stent occlusion on one side. So that means the blood vessels in his thigh are completely blocked, and the vessel behind his knee on one side is completely blocked. And he came to me for a second opinion, and he exercises, walks on the treadmill 45 minutes, 3 to 4 times a week. And he was told by another facility that he needed major intervention to both of his legs. And he was very concerned about, because of his age, that he did not want aggressive intervention. And so, talking with him and coaching him, listen, I can't improve any more on walking on a treadmill 45 minutes, 3 to 4 times a week. I can't make you any better, but I could certainly make things worse. And so he has been able to manage his peripheral artery disease, very significant, just like the patient you were talking about, with exercise and diet. And just to put a little exclamation point on that, when he contracted COVID earlier this summer and he couldn't walk like he normally did for 2 weeks, he said it really took some time to be able to build that back up again because his muscles really need that continued activation and attention. So you're absolutely right that there are so many other things that we need to be able to discuss and offer with our patients that are non-surgical as well.
That's a really inspiring story. We just had one today that she lives in the middle of nowhere. She's out in her yard all the time doing all kinds of stuff. And she went in yesterday and Wednesday actually. And I couldn't understand because listening to her, she was pretty active, and I felt like we could get her on a regimented walking program and she would see improvements. And she said the doctor was going to put her on the table on Wednesday, and this was a vascular surgeon. I said, I don't understand. She said, well, he's going to do a diagnostic angiogram, and if he sees something, he'll fix it. And I said, but why doesn't he just do a CT angiogram, look at it, and you seem to be doing okay? And she went ahead with it. She told him that she did not want him to touch anything when he went in there, which was good. So he didn't. He said he wasn't planning on it anyway because he found CTOs, chronic total occlusions, in both femoral arteries, the SFA, and that reconstituted just above the knee. And he was suggesting that if they did do something, it wouldn't be intervention, and he would do bilateral bypasses. So he would do a bypass, femoral bypass on the left and the right. And I'm thinking, God, that seems awfully aggressive for someone who's a 76-year-old woman who yeah, she has cramping and such, but it's not debilitating. She's not waking up in the middle of the night in pain. She's getting full sleep and she's more active than most 76-year-olds. So I'm curious in that case, um, what would you do? You would say, I would imagine, just keep walking.
So there's multiple different things. Like as you talked about before, I really take a holistic approach to patient care as well as arterial disease. Arterial disease builds up because of all of our lifestyle decisions. This is a lifestyle disease. There's no way around it. It comes from our diet, it comes from our exercise, it comes from our stress levels as well. And so
Mm.
talking with the patient about how can you maximize your blood vessels? What is good blood vessel health? These vessels are not lead pipes. I know everybody says we're plumbers and these are pipe systems, but these are not pipes. This is a biological system. These vessels actually act like a muscle. So the more that you use them, they actually behave better. They release relaxing hormones, and then you get all the other benefits that go along with the actual exercise. And so it's not just exercise, it's also what are you eating? How are you sleeping? What are you doing to manage your stress? Because you can have the perfect diet, you can exercise every day, but if you are not managing your stress appropriately, your cortisol levels, which is the stress hormone, can be absolutely through the roof. They also become dysregulated with poor sleep. And when that happens, you're actually depositing more fat, more plaque within your blood vessel walls, and they become harder and harder. So it's not this isolated treatment for these patients. They need to understand about what is actually affecting this disease, what are things that I have control over, and then talking with the patient. And so that's when you implement all of these different multifaceted strategies into treating this disease process. And then you have the patient go and apply them to their life. And then you come back and check in with the patient. And then say, okay, you're doing great. Let's see how you do after 6 months. And then that's how you manage these patients, especially our older patient population. These are 76-year-old blood vessels, 80-year-old blood vessels. They don't behave the same way as 50 and 60-year-old blood vessels.
Would you talk about your interdisciplinary approach to treating these patients and how you, or should I say multidisciplinary, like how do you involve a team in treating these patients? Because most of these patients are not just PAD patients. They have a lot of other things going on.
So one of the things that we capture as soon as I see a patient in clinic, we try to capture their entire healthcare team. Who is your cardiologist? Who is your nephrologist? Who is your endocrine doctor? Who is your podiatrist? Who are you seeing for wound care? And some of the patients may not be seeing all of those different specialists, but some of them are. We try to capture their whole entire healthcare team. And if they don't have someone that is needed on their healthcare team, specifically wound care or a foot and ankle specialist, well, then we refer them to someone. And with that, I have a collection of people that understand limb salvage and the detail and the attention that it takes. And once we partner with people, we are in constant communication about these patients. It is not uncommon for my phone to have multiple different foot wounds all through my picture sections because we're monitoring the progression and they're keeping me updated because as a surgeon, I can't see every patient every week, but wound care, that's what they're doing. They are monitoring, they are seeing this patient every week, and they are keeping me updated. And so then the patients don't need an ultrasound every week. They don't need an ultrasound every month, but we need to have a way of good communication to keep tabs on these patients about how their wound is progressing. And so we really partner with all of these different specialties because limb salvage needs a multidisciplinary approach. The data has just shown it over and over. Patients do better, limb salvage increases when you have this multidisciplinary approach. They got to have their diabetes controlled in order to even heal that wound. Well, I don't treat diabetes. And so I work with their endocrinologist or their primary care doctor, whoever's managing their diabetes, to really have that good connection and attention to that aspect of limb salvage.
I love that you surround yourself with people that actually and help to educate some of those other doctors in other practice areas about PAD and about advanced limb salvage, about critical limb ischemia, because patients always say, "Well, I don't have an appointment with my vascular surgeon for 6 months." But I said, in the in between time, aren't you seeing your primary care? Aren't you seeing your endocrinologist? Aren't you seeing your podiatrist? In every one of those situations, if one of those doctors understands limb salvage, understands CLI, every single appointment, no matter what appointment it is, they're going to tell the patient, I want you to take your socks off.
Yep.
I'm just going to take a quick look at the feet, because then they're going to be able to get on the phone with you and say, hey, I just noticed a wound that is developed. You might want to get them in earlier for an additional ultrasound.
And that's what we also communicate with the patients as well. You need to put, this is what a technique that I learned in residency for, especially for our diabetic patients. Across from your toilet, you're going to put a little mirror leaning against the wall or wherever. And every time you sit down every day, you're going to lift up your feet and you're going to look at the bottom of your feet in that mirror. And if there is any type of wound or pinpoint wound that develops, either your wound care specialist that I work in concert with needs to know about it, or my office needs to know about it. And then from there, we make decisions about what the next step is. But again, we have to keep educating the patient so they become our partner in care and not just this victim of the medical system.
I love that. So, what sort of research interests you? Are you participating in these days? Any clinical trials for any medical devices or any techniques that you are really excited about?
We're a very small practice. I'm not in academics. I'm actually a private practice. So at this point, we have some research that we're looking into. It is not with peripheral artery disease, but I absolutely appreciate all the conferences and participate in those to see about what are we doing that's advancing wound salvage and limb salvage, even with wound care. So I am constantly reading new articles. I participate in the journal club with our local university, as well as looking and partnering with industry. I actually really enjoy because it helps me understand the mechanism and what I'm actually doing with these devices, that going and seeing where are these devices manufactured, how are they manufactured, talking with their engineers about what's coming down the line, what are things that we can be looking at. So absolutely, as a limb salvage, we still don't have the best tools available yet. And this is always one of the things that drew me to vascular surgery, is this cutting edge technique, this creativity, this constant curiosity of how can we improve. And so this is absolutely the part of vascular surgery that has the most advancement within the last, decade even.
And still so much more to come. I just visited, as you said, I love visiting the companies. And I had the opportunity to visit a company called LimFlow. I'm not LimFlow, Reflow. They're all flows. Reflow Medical down in Southern California. And it was fascinating to see that they have this new, what they call the spur technology, and it's a retractable stent, which I think could end up um, increasing the number of people willing to treat those below the knee vessels. I think so many are afraid to treat those below the knee vessels because they are so fragile, and you always want to leave that landing zone open in case for the need for a bypass as that last ditch resort, right? And it's so easy to go in there and hurt those vessels. But with this retractable stent, you're not leaving anything behind. And you can go in there with a little less trauma, I think, from what I was seeing and from what I've been hearing. And it still leaves more options available if in fact that does fail and the patient needs to have a repeat treatment, God forbid. I'm curious
Let
if
me
you'd
tell
had
you
any
why
familiarity.
yeah, so let me tell you why I'm excited about that technology with the retrievable stent. So, like you said, it's an actual spur technology where you penetrate the intima, the inner lining of the blood vessel, in multiple different areas, and then you remove so you leave nothing behind. So when I see that, I'm thinking about how about doing a drug-coated balloon angioplasty after that? So now with all that spurs, now do we have better drug delivery to the intima to decrease the reintervention rates, the restenosis rate after that? So absolutely, I know exactly what you're talking about. They've got these cool conformable catheters. I'm excited to trial those out in our OBL very soon. So I absolutely agree. There are so many interesting things and new things that are coming down the line because below the knee, those tiny vessels in the calf and the foot, those really are very difficult to treat. And especially with the diabetes epidemic that continues to grow, not only in our country, but around the world. I'm so afraid that if we do not keep pace with new advanced technologies, our amputation rates are going to go up.
Yep, and it's frustrating. I mean, I understand, there are a lot of vascular surgeons and other interventionalists that refuse to treat below the knee. They don't even tell the patient that it's even possible to treat below the knee. They treat to the knee, and then if there are blockages below, they just say there's nothing that can be done. Just go ahead and walk, and when you can't walk anymore, we'll just amputate. But or they'll go in, they'll get the faucet going, they'll turn on the faucet above, they'll fix the iliacs, they'll fix the superficial femoral artery, they might fix the common femoral, and then they hope that maybe with the turning on the faucet that maybe, the vessels below, maybe with some walking, they'll build some collateral vessels and be able to develop some additional flow around, the blockages in below the knee. But a lot of the times in my experience, it just doesn't happen. And I'm hoping that, and I understand their theory behind that, but I'm hoping that once we have some of these new technologies, that maybe they'll be willing to go in with a less is more approach and at least get the patients a little bit more blood flow down to their feet, in order to improve their symptoms and get them walking more.
So, with regards to that, like you were saying, treating the larger vessels, that should absolutely be done first. But as
Right?
you're saying, it is inadequate treatment if the patient has a wound to not restore inline flow. And inline flow means there is direct flow from their heart all the way to their foot. Without that pressurized inline flow, it is very difficult to heal that wound. And certainly there are some instances, especially in some of our octogenarians, our 80-year-old and 90-year-old patients, they may not have the ability to restore inline flow.
Yeah.
In that sense, in those specialized patients, you're doing the best you can and with wound care because, again, they have 80 and 90-year-old arteries. And you're not going to put them through necessarily a 90-year-old through a major bypass. That's not an option for them. And so again, now you're tailoring it to that specific patient population or that specific patient. But if you have patients and they have wounds and their interventionalist, their surgeon, whoever it is, says, well, let's just see if this works. Unless they've told them you absolutely have no other option, they need to get a second opinion and they need to, before it's, let's just see how it does. Because if they have a wound, they have to have that pressurized inline flow to heal that.
Yep. Especially if they have a wound. I mean, the goal really is to really get those patients before they develop a wound. I mean, we had a patient that we just got that it's taken them 7 years to actually completely heal the foot, and literally in just the past few days they've gotten it to complete healing. I mean, it started out where the patient was diagnosed with diabetes at a very large famous hospital, and they just started cutting off toe by toe by toe, and then it was transmetatarsal, and then it was half the foot, and before they found us and found out, oh wow, there's something called peripheral artery disease, and oh, doctor, can we do anything to improve circulation? And then the doctor went in and open up the arteries to the knee. Didn't bother to open up below the knee, said there's nothing more that can be done. Didn't even tell him it was blocked below the knee, just said, sorry, if that doesn't improve anything, then there's nothing that we could do. They then wanted to do a below the knee amputation because symptoms didn't improve, the wound didn't heal. And I said, you know what, it's time, I get a second opinion. And it turns out that they had barely one vessel run off into the foot. And they were able to go in and open up, get more flow in that one vessel, but then open up one more vessel. So they have a good amount of flow to be able to heal the wound. But the damage really was already done to try and heal up those points of amputation at that point. And so I think that we need to get to a point, and I think you're in agreement, where we're not waiting till they're literally a toe stub away from amputation. We got to get these patients when they're asymptomatic, get them diagnosed, get them on a walking program, get their diabetes under control, get their kidney disease under control and properly medicated, and get them to quit smoking if they're smoking, get them active, so they don't get to the point where they're literally, I mean, those wounds cost so much time and energy and money to try to heal them.
Well, and like you said, some of these people are still in their working years, and the loss of productivity to them, their family, and our country as a whole is absolutely huge. I mean, it's in the billions of dollars. And so, like you said, the education platform, and I know that my society, the Society of Vascular Surgery, we're becoming very aggressive on our marketing, because even within the medical community, there's a lot of people that don't even know what I do or even the advanced capabilities. So, in my small corner of the world, we absolutely love to educate. We love to go to lunch and learns at podiatry offices, wound care facilities, as well as primary care doctors, and letting them know how can we partner with them and make sure that we're all on the same page of diagnosing these early, as well as doing the appropriate treatment and long-term management of these patients. And so I just am so grateful that the global PAD network is doing this, is reaching patients right where they are and being that resource of education and letting them know, hey, look at other options before you end up with an amputation. Now, can we prevent every single amputation? Unfortunately, we can't. But by gosh, we're going to try, and we're going to talk this patient and walk them through where they are, how can we help, and what are options for them, even if it is amputation.
What's so really frustrating for me, and I don't know about you and what you hear and what you see in your circles, but even just yesterday, we had a patient that they were telling the patient that, and the family, that above knee amputation is the best. It's just going to be in a revolving door of treatments. Let's just cut it off now. Why delay the inevitable? Didn't bother to tell the patient that literally across town at another hospital, there's another vascular surgeon that performs limb salvage. And so they just cut off this guy's leg. And I tried to convince the family to say, hey, there is another option across town. Let's get a hospital to hospital transfer. Let's get them out even today, discharged. We'll drive them right over to there to the other emergency room. They'll receive them. They'll get them in. They'll perform some advanced limb salvage techniques, at least give the guy, a former military guy, one of our veterans that served our country, let's give him the best chance to keep, his legs. And they're still not doing it. There's so many doctors still arguing for their own limitations and not giving up the patient. They're giving up on the patient, not giving up the patient, not respecting the fact that these people respect someone with a white coat, with authority, and trust them. There's so much trust and faith that goes into it. And so many of these patients come to me afterwards like, oh my gosh, I didn't know there might have been another option. I now live in regret because, wow, why did I trust this doctor? Why are there so many doctors that literally are not following Society for Vascular Surgery guidelines that state, give the patient the best chance at keeping that limb by restoring that inline blood flow. They're just not doing it. More than 60% of all amputations are being performed without a doctor doing it, 90% of which aren't even getting a vascular evaluation in the year prior. I just don't understand, especially when I see an amazing vascular surgeon like you who's leading by example, who's doing it. You're actually exhausting all efforts to save life and limb. Why are so many still not getting it? I just don't understand.
Well, and I think that this is a changing because vascular surgery is relatively I would say, a newer specialty. We really came about in the endovascular age in the 1990s. And so understanding all of the amazing things that we can do, certainly the younger generation coming up and our leaders in the societies are really trying to get the word out. We're trying to make sure that people understand this. And one of the things that we are changing as a society is definitely our ego, in the sense that there are other people, there are other specialties, and there are other physicians that may be able to do something that we can't. And I make sure that I tell my patients, I was like, you are never going to hurt my feelings if you say, I would like a second opinion. I am happy to help facilitate that. I will recommend people and I will help you and provide any data or data points that you need, like ultrasound, angiograms, any of that, because I want the best for the patient. And I think understanding that and keeping that humility that, in my hands, maybe I can't save every foot or every leg, but happily I'll say, let someone else try. And I think you and I had this conversation the other day that even some patients that I'll try to open a chronic total occlusion, a super blocked artery, and I just cannot get through it. And before I tell the patient, you're getting an amputation, a lot of times I'll say, let me try a second time. Let me just give you a rest, come back in 10 days. Let's try a second angiogram. And for whatever reason, sometimes the plaque has shifted, something has happened. I made enough of a dent in it last time that approaching from a different angle, because it really is millimeters of difference that can make a difference between that wire going through and not being able to revascularize. And there are so many times that we're able to then recanalize, get that patient open. And so understanding the actual pathophysiology, what is happening in this blood vessel that's causing this blockage, and what are techniques on how to get through that, those things are so important. And so, like you said, having that network of people within your own community, whether it's interventional cardiologists, interventional radiologists, other vascular surgeons, let's keep this a collective focus on the patient, that how can we better serve our community, and serving our community better makes all of us stronger and better. And so those are the things that I hope that we're making a difference, especially here in Memphis.
And if anyone had any question as to why she is the U.S. Vascular Surgeon of the Year, right there, right there. God, you just gave me chills. I have three more questions for you. These are some doozies. I'm gonna warn you. It's for the first one is for a series called Journey to Diagnosis, and I want you to share a case that had you scratching your head as to how in the world did this patient not get diagnosed sooner? How was this missed? And you could even take it in the direction of how in the world did our healthcare system waste so much money on all of these other procedures that never relieved a patient's symptoms? They should have just been diagnosed with PAD, treated for PAD. They never needed a spinal fusion.
So I'd like to do a little twist on that question. And the fact that I would say, how did this patient not get to a vascular surgeon? And so I have a patient who had been treated at an interventional outpatient facility for 2 years, and had multiple interventions to his common femoral artery and profunda femoris artery, and multiple times had never had inline flow restored to his leg. And so what had happened is they went in and did multiple balloons to their common femoral artery and deep femoral artery. And the patient had some pain that resolved, but the pain persisted for years in this patient. Continued to follow up with the same specialty and specialist in this group, but was never given that opportunity because they couldn't cross the blockages of getting them to a vascular surgeon. And I really want your patients to know that this is the special I guess the special technique of a vascular surgeon. Not only can we do advanced work on the blood vessels from inside, but we can also do open bypass surgeries. And these are all, both of these are limb salvage techniques. Both of these can save legs and save limbs. And so even if there is someone saying, I can't get through this blockage in, of the blood vessel, I encourage patients and people to say, can you refer me to a vascular surgeon? Because some of these patients are getting stopped and not getting that last or that advanced level limb salvage referral. And before a patient is told by anyone, can you get me to a limb salvage vascular surgeon?
And I think it works kind of across the board, across practices, because it can also work conversely. There are some vascular surgeons that can't do advanced endovascular. And so it can work across. But where you're coming from as well is, I cringe because you said the common femoral artery. And still, no matter what, the gold standard is endarterectomy, right? And so I just cringe when people talk about, because usually those common femorals, they get to a point where they have so much plaque. They're good sized vessels, right? I mean, they get to the point where, you know what? You need a lot more flow than what an endovascular approach can do. And endarterectomy is still that gold standard, and you got to get to a vascular surgeon, especially with that vessel, to really get that maximum luminal gain in that situation. And so it's really good to have one, always get a second opinion. And number two is always have multiple practices. And even with the interventional cardiologist, I like them to work very closely with a vascular surgeon, because they can also help you with your heart. And so what I love about you as well is that you're like, hey, you know what? I don't need to own the patient. We can all work together. And you know what? I'm not going to steal your patient from you. I might be able to do an endarterectomy of the common femoral, but hey, you can still work with this patient and treat their heart.
That's absolutely right. Again, we're trying to keep this as a patient focused and not the physician focused. And
Yeah.
so being able to partner with the cardiologist, the interventional radiologist, my partner's an interventional radiologist. So being able to partner with all of these endovascular specialties, this is the absolute way of the future. And
Yeah.
unless we are tackling these disease processes together, we are leaving patients untreated. There's just not enough vascular surgeons out there at this moment to take care of all this PAD in the world. There just isn't. And
Yeah.
so being able to have that trusting relationship with your cardiologist, especially your interventional cardiologist, that they'll say, hey, you know what? I did treat this SFA disease, but wow, they've really got a wound. They've got their whole entire tibial vessels. I'm not comfortable doing that. Do you mind taking a look at this patient? And I'll say, send them over. Happy to see them. Let's figure out how we can take care of them.
Yeah. I love that. And you know who we talked to the other day? He's our global luminary of the year. It's Dr. Athanasios Saratzis. He's a professor of vascular surgery out of England, and he was talking about he was all endo before, endovascular, doing things minimally invasive, and then he had this one patient, which was so inspiring, the story, and it still seems to hurt him today, that he really wished he would have made the decision sooner to say, you know what, we need to do a bypass. And so now all of his research is really focused on really getting a better understanding of the aortoiliac disease and doing more research on whether or in what specific cases and what specific case would bypass be more effective and better for the patient. Not just effective, but better for certain individual patients. And so I really like your approach. I like that you're working with an IR, because IRs also they have some additional training in pain management. And so there are different things that they can do, such as cryotherapy and things like that for patients that have the consistent pain, that even if you've revascularized, they might be able to step in and help with another option. So that's great. My second, and then I have a final one. So 6 minutes that mattered. This is a series. So share 6 minutes that mattered in your career. It has to be a defining moment, a catalyst for change, a spark that led you in a certain direction. It could be a conversation that you had with someone that led you in a particular direction. It could have been a moment in a movie, a show, a documentary, or something you witnessed that was eye-opening. What were the 6 minutes? What was that moment that mattered for you in your career?
So, one of the things that drastically changed my approach to this holistic approach to patients is I watched this documentary called Forks Over Knives. And this documentary really changed my mind on how I'm actually approaching the chronic treatment of these patients, because these patients become my patients for life. I see them for the rest of their lives because I do not cure their disease. And so this documentary, I actually prescribe it to some patients and say, I need you to watch this. I need you to understand what's going on. And the history behind this documentary is there was a cardiothoracic surgeon that was doing heart bypasses all the time. And he said, eventually I got to the point where, wow, I'm just putting a band-aid on this. Am I really helping these patients? And then he really dug in and partnered with an epidemiologist to look at what is actually causing that heart disease. And that is where it became that diet was really affecting and causing this disease progression. And so when I watched this documentary, then I started doing a deep dive into, wow, am I really doing everything I can for my patient if I'm not talking about their diet? And then that really changed my practice. And so then I was like, well, what else should I be talking to my patient about? And what are other contributors to peripheral artery disease, carotid artery disease, all the disease processes that I treat? And so then that really kind of took me down this whole entire other road. And we can talk some later about how meditation and doing mental Tai Chi and different things like that that you're doing with your patients, these things that are absolutely free to do, that can make these huge impacts on these patients' lives, their wound healing capability, as well as their long-term survival. So that was
Oh,
something that
that's
absolutely changed how I practice medicine.
Oh, you would love a couple of our we have a breathing expert, Rabia Hayek, that we have coming on once every couple months, who's incredible, that focuses on meditation. Need to send you one of those videos. And then we also have the Tai Chi on Mondays, but we also do heart math with our patients, and Wim Hof breathing as well with
That's
our
right.
patients. And we find such great results from it. And one more question for me, and then if you don't mind, Heinz, one of our in studio audience, has a question for you as well. But we have this Pulse series, and we want you to share a case, a specific case with a big lesson for you, as well as for others. Describe the patient, the frustration with case, and the lesson that you learned that others can learn from it. It could have been a success, it could have been a failure. In both cases, there's something that we can learn. So share your case.
So I have a case that has success and failure all wrapped up into this one instance. So I had a 75-year-old female that had multiple left leg angiograms for claudication. She had ended up with a superficial femoral artery stent, a popliteal artery stent, and tibial stents, all at an outpatient place. 3 months later, she ended up with all of those occluding, and she had to go to a major hospital in the area and had to get thrombolysis, which is clot busting medicine, delivered to try to open up the blood vessels. which did not work. Well, actually it worked, and then she developed what we call compartment syndrome. Compartment syndrome is where the legs and the lower calf, the muscles swell so much against this outer layer on the muscles that it actually causes the muscles and the nerves to die. She ended up with foot drop, where her foot is completely in this drop position. And she had these non-healing fasciotomy sites. And I'm talking long incision sites on her leg that were non-healing. The doctor that had seen her at the major hospital center told her that she just needed an amputation. And she refused. And she was discharged, and she had been undergoing wound care for approximately 7 months, trying to get this wound to heal. She was then sent to me as a second opinion. And when I saw her and I performed imaging evaluation and looked at everything, and I looked at all the images from the hospital, I initially told her, I really think you need an amputation. Your foot is not salvageable, in the sense that you have this foot drop and you are going to be in significant pain. You are probably not going to walk appropriately again. However, with an amputation, you could be up and walking within 3 months. And talked with her and extensively with her husband and her, and she agreed. And then 2 days before the amputation procedure, I got called by the wound care. Uh, she's a physical therapist, wound care physical therapist specialist. And she just said, just please try to do an angiogram on her. And I said, I really think that this is futile. She's like, please just try. And I said, okay, I will try. And we tried and we worked, and we were able to restore blood flow to her leg. We were able to open up all of those stents, and she has healed those fasciotomy wounds. She still has permanent foot drop, but she is motivated and she wants to go through physical therapy, because the thing that she wants to do is she wants to be able to stand in the kitchen and cook with her husband. She doesn't want to go run a marathon. She knows that she's probably not going to be walking around shopping with her girlfriends without the assistance of a wheelchair or something like that. But her goal is just to be able to stand in the kitchen and cook with her husband. And so from this case, I learned to really listen to what the patient wants, and to give an effort and give your best effort to the patient. And then at that point, even if I hadn't been successful on that angiogram, she and I would have known that we did our absolute best to try one last time before we committed her to an above the knee amputation. And it really taught me a lot to not underestimate, one, my capability, and two, to listen to the patient and try to meet them where they are as best they can. And so
You're gonna make me cry.
that was a recent story that really, at this point, I just saw the patient in clinic again this week, and she is hopeful and she is doing well and working with physical therapy, and she's able to move her foot just a little bit more, and she's willing to put in the work.
Wow. Because yesterday with this one patient, they did the fasciotomy, they had the thrombolysis, they ended up with the fasciotomy, compartmental syndrome, and they told the family that they needed an above knee amputation, never even bothered to try any further. And that's the one I wanted to get across town to get them to try. And the family was just like, yes, ma'am, yes, sir, to their hospital, and just decided together that the amputation was the best. And I looked at this man's feet, and while there was some gangrene, it wasn't from what you and I have seen, some serious things that were even still salvageable. We couldn't believe were salvageable. His foot, he was still moving it. It didn't look bad, and they let him cut off his leg. And it just, I played in my mind over and over again, just what could I have said differently? And it's so frustrating. And then to hear this, I'm like, oh, you just reaffirmed that they should have just tried, got someone else to try. Doctors just don't give up on the patient, give up the patient. Let someone try. And so, God, it's amazing. You are just awesome. I mean, no joke. And before we go, I know you have to go. We've kept you more than an hour here, but Heinz does have a question for you if you don't mind.
Sure.
Hey, doctor. Thanks for joining and congratulations. You had some fascinating stories. My question is related to I have one leg with pad, the other leg's fine. SFA had stent, pop was cleaned out and ballooned and all that a year and a half ago. I've been walking like 6.5 miles every day.
Oh, wow.
Yeah, I'm walkaholic basically. With that though, I feel my pad's coming back. However, unlike previous times where I had calf pain, I'm getting foot pain, not calf pain. But all of a sudden, when I walk a greater distance, it's like all of a sudden the floodgates open and I'm getting normal walking again without the pain. Does that make sense that it could be bypassing the calves and my problem is in the foot, even though it's up in the SFA and pop artery, and all of a sudden my foot says, "Oh, here's blood. Let's pump it around." And then I'm doing okay. And when I say that, it's like 45 minutes later after I start the walking.
So it could be that you've had progression or now disease that's a little bit closer to the foot. And so I know that you're probably getting regular ultrasounds to monitor these stents and to make sure that they're doing what they're supposed to be doing. Because it's different when you have stents. When stents are placed in the leg, we know they're going to fail eventually. And that's what our job is as vascular surgeons or interventionalists, to monitor these stents and try to pick up any kind of scar tissue or anything like that before it fails. So typically, if you have re-narrowing of the stent that's in the thigh, you would have symptoms downstream from that in the calf or even in the foot. And so if you're not having the pain in the calf, it may be that you have some disease that's developed in the foot, or it may not even be related to your peripheral artery disease. It could be musculoskeletal. It could be electrolyte imbalance. Another one of the things that actually can cause the cramping and discomfort is our magnesium, our calcium, our potassium is not in the optimal balance, and you need that for your muscles to function.
Okay, thank you. I got a second question, if you don't mind, Kim, real quick. I know what they do if you have radiation-induced problems in your carotid and in your heart and all that. What would you do on the leg? Radiation-induced pad.
Sure. And some of that is, I've got a couple of patients like that, and we actually do endovascular interventions on those patients. They have a different type of surveillance that we follow. There's other types of medication that I would try in those types of patients, and one of them would be called Pletol. Pletol is a type of medication that can actually decrease intimal hyperplasia, and radiation-induced arteritis actually has like intimal hyperplasia as well as other pathophysiologies that are like on steroids. So I would try to get them on a long-term medication like that as well.
But when you say endovascular, what does that mean to me? What, is a stent still warranted, or
Yeah, so
is it
it's a
just
stent.
ballooning or just walk to death?
Correct. It can be a combination of all of those things. And so it really depends on each type of lesion is a little different. And so it just depends on the severity of the lesion, the type of symptoms the patient is having, to tailor that to what they need. But yes, a stent is possible, balloon is possible, atherectomy is possible. Really depends on what's going on with each patient.
Okay, thanks. Thanks.
You're welcome.
Thank you so much. Dr. Jacqueline Majors, our U.S. Vascular Surgeon of the Year for 2024. Congratulations, Dr. Majors. Thank you so much for all you do to exhaust efforts to save life and limb.
Thank you, Kim. I appreciate being here.